Welcome to my talk on mast cell tumours. This is Richard Elders from the Oncology department. This presentation is about mast cell tumours. We'll start off with canine and then move on to the feline. Already from the history taking with the client, we're looking for factors which might signify a change in prognosis or biological behaviour that might change treatment patterns for us or treatment decisions. So breeds such as brachycephalics of any kind and schnauzers, as well as several other breeds, tend to have more frequent but perhaps less aggressive mast cell tumours, whereas the Sharp A tends to be affected at a very young age with more aggressive mast cell tumours. Those mast cell tumours that have been present for 6 months without changing generally aren't too bad compared to other features, and those presenting at a young age often have less aggressive mast cell tumours. We're also looking for a lack of systemic signs that might go hand in hand either with dissemination or mere degranulation, but an absence of systemic signs is usually a good sign. There are a couple of physical factors which can suggest much more aggressive behaviour. For example, satellite lesions, where there's a small lesion in the periphery but very close to the main mass, both of which are mast cell tumours, that can signify a very invasive growth pattern. Recurrent masses tend to be at least as poorly behaved as the original mass, possibly even worse behaved than the original mass. And some locations, although I find this perhaps a little bit less reliable. So for mucosal mast cell tumours that aren't on the conjunctiva, there definitely is an increased metastatic rate, maybe up to 50%. That includes the mucocutaneous junctions, so anything mucosal at all other than the conjunctiva. But maybe scrotal, inguinal and muscle mast cell tumours, as long as they're very much within the haired skin, this may just reflect surgical difficulty. In terms of the diagnosis and the initial workup, finite aspirate is hard to beat because we expect them to be diagnostically accurate in greater than 90% of these tumours. Admittedly, I see a lot of enthusiastic clients, perhaps who have lots of insurance or are well resourced, so I do a lot of staging up front, but it can be valid still to stage later and maybe after surgery do staging if that seems more highly indicated based on the histopathology. Although cytological grading is becoming more of a recognised feature, I tend to kind of preserve judgment until there's the histopathology grading in, but that may become more relevant with regard to non-surgical treatments, perhaps such as Stelfonta. Applying the staging scheme is a little bit controversial because some things have changed. Regarding multiple dermal mast cell tumours, multiplicity is probably not that significant, whereas satellite lesions and other physical factors have not yet entered the staging scheme that we use. And staging is very strongly linked with the risk of metastasis, as you can see here. For lymph node cytology, if you're sending samples to the lab, hopefully they'll use the system designed by Crick et al., in which they classified how likely metastasis was based on the description of the cytology. And I've included in this table from that paper the median survival time measured in years, which was used in the follow-up of these patients. So as the metastasis becomes more certain, then the median survival time decreases quite substantially. However, there's been lots and lots of recent papers on the lack of reliability in terms of cytology versus histopathology. So in many papers, around about a third or so of histopathologically evident metastases in lymph nodes will be cytologically missed, sadly. So there's very much an emphasis that histopathology is the gold standard for evaluating lymph node metastasis in mast cell tumours. Similar to the previous slide, Weishauer et al. In 2014 designed a system by which to assess the likelihood of metastasis in lymph nodes, shown in this table, and they presented some proof that the later stages of metastasis seem to have a worse survival than the non-metastatic to pre-metastatic stages of lymph node involvement. However, this obsession with lymph node status does not reflect the lack of consensus in the literature with regard to the impact of lymph node status on treatment decisions and on prognosis. Although there are several papers in most oncologists with regard to established metastasis in the lymph node as being worthy of lymphadenectomy and then additional systemic treatment because the metastasis is probably spread beyond the lymph node if it's established within the lymph node. That's not the finding of all papers. So for example, Chaffin et al. In 2002 found that with no chemotherapy and just prednisolone after surgery and radiation therapy on the primary and lymph node sites, there was a very long median survival time. And very recently, Marcinato et al. Found that chemotherapy made no significant difference in terms of survival for grade 1 and 2 lymph node mast cell tumours with early lymph node metastasis. However, that was not a randomized patient population. So perhaps there was some lack of standardization as to which patients received which treatments beyond surgery. However, as in red at the bottom of the screen, we only really can make these decisions when we have the most robust information. So a lot of the advice calls that I take will end in advice to take the lymph node with the primary mass or at scar revision if revision surgery is necessary for a narrowly excised mass, because cytology misses so many of the histopathologically evident metastases. Sadly for those dogs with established mast cell metastasis beyond the lymph node, survival tends to be relatively short. Similar to other diseases such as lymphoma or histiocytic sarcoma, perhaps the impact on the structure or architecture of the spleen and liver might not be affected by mast cell infiltration. So I generally use the ultrasound just to label the slides appropriately, spleen or liver, and I don't tend to rely much on the features within the ultrasound report, just on the cytology. There was previous research to suggest that if the lymph node were negative with regard to metastasis, there was no need to stage further, and perhaps going along with the lack of robustness from lymph node cytology, it's been fairly recently shown that we can have distant metastasis or visceral metastasis without overt lymph node metastasis, including in some patients with a grade 1 mast cell tumour. But as I mentioned at the start, sadly, survival time tends to be measured in just a handful of months, even when chemotherapy is used and even when the primary disease is effectively dealt with through surgery and or radiation therapy. So regarding preoperative biopsy, it's been a long time since I did a preoperative biopsy to find the grade before an attempt at excision. And to be honest, the reason is because I'm rubbish at surgery. I can't operate to save my life, but I've always worked with surgeons who are really, really great at surgery, including reconstructive techniques. So for my patients, almost always there's going to be a combination of either surgery with radiation therapy or just surgery on its own as a definitive solution to the primary mass. So I would only very rarely use prednisolone or prednisolone with chemotherapy to try and neoadjuvantly shrink masses before the definitive attempt at surgery. This aspect of mast cell tumours in dogs may have changed recently with regard to the use of Stelfonta, because that's another additional option for treatment of the primary disease. However, the main reason that I don't tend to do so many preoperative biopsies is that if the local anatomy is limiting and a biopsy suggests that it's a low grade or grade 1 tumour, I'm probably not going to suggest that we do a less than good excision or less than maximal excision in the anatomically limiting area. So for me, it doesn't really have that much of an impact on the surgical approach, given that the surgeon is probably going to do a maximal surgery that the local anatomy will allow. There was a recent Australian study looking at wedges and punches and true cut samples as a preoperative biopsy, and they were all fairly accurate. But like I mentioned, the way that I and the surgeons around me tend to work would suggest that the impact of a preoperative biopsy is actually quite low in terms of incision and other therapeutic decisions. So almost all of the patients that I see with a mast cell tumour are going to have surgery, and then we're reliant on the pathologist's opinion as to which mast cells look malignant or neoplastic and which do not, especially at the surgical margin. In terms of incision, there was a paper a few years ago suggesting that there was no recurrence with a 10mm lateral margin and a 4mm deep margin at surgery. We know that those margins shrink when they're taken off the patient and when they're exposed to preservatives. And so on histopathology, there's a few papers that suggest that with a histopathology microscopically red margin of 3mm or more, the risk of recurrence is minimal. But just echoing the previous slide, if the local anatomy allows you to take more than 10 millimeters of a lateral margin or 4 millimeters of a deep margin, including a fascial plane perhaps, then as long as the surgical morbidity isn't going to be greater, why not go for the more reassuring excision, which is most likely to give you the result that we want on histopathological measurement of the margins. But incomplete margins are not the end of the world, although we wouldn't necessarily aim for those. So the lowest risk of recurrence that I've read of for grade 2 cutaneous mast cell tumours incompletely resected is 23% with long-term follow-up, so 77% did not recur. Admittedly, that is cherry picking the best paper, and lots of other papers have shown much higher risks of recurrence. When similar tumours with low proliferation indices are incompletely excised, the risk is even lower, maybe down to 11%, and the risk for subcutaneous mast cell tumours with incomplete margins at excision is around about 12%. So how to react to margin status? Well, some papers will suggest that there should really be no reaction and margins don't make a difference, which is what we genuinely talk about in cats. But even looking at that 23% risk for the average grade 2 mast cell tumour in dogs with incomplete resection on the last slide, 23% is still a very large minority. So a lot of clients will opt to have some form of intervention with those type of risks. And there is an excellent paper from 2014 by Clin et al., which showed that whether we use a repeat surgery or radiation therapy in response to narrow or incomplete margins, the median survival time is very much longer than if we use neither surgery nor radiation therapy, or possibly just rely on chemotherapy. And so this would kind of suggest that we should use surgery and radiation therapy against the local risk of recurrence, and then preferably use systemic therapies like chemotherapy against the risk of dissemination. As far as I'm aware, the current advice from the Oncology Pathology Working Group, which is a collaboration between pathologists and oncologists, is still recommending that both grading schemes are reported when a histopathological submission is made. So hopefully your report from a mast cell tumour will include the patenate grade based on 1, 2, and 3, with 1 being the least aggressive and 3 being the most aggressive mast cell tumours. There's been several studies to show disagreement between pathologists when they're presented with the same material for grading. But for me, I find it very unsettling to say that grade 1 mast cell tumours are benign because a few of them will metastasize, and also there's a chance of misclassification. So perhaps some grade 2 mast cell tumours sneaking into the grade 1 designation inappropriately. So I never really refer to my grade 1 mast cell tumours as being benign and kind of completely sorted after even a narrow margin of excision. The other grading scheme which should be applied to all histopathological assessments is the now 10-year-old Kupel grading scheme, with 4 criteria of deciding whether the mast cell tumour is either high grade or low grade. This is much less variable, only has 1 slightly opinion-based criterion within, and so there was a high level of agreement between the pathologists that established this grading scheme. And there was a huge difference in the prognosis between high and low grade, with the initial paper suggesting that high grade tumours had a median survival time of 4 months, although not all of them had chemotherapy after the surgery. With more pathologists and more patients being graded according to this scheme, perhaps the impact of having a high grade designation is becoming less over time. And so in a recent paper with no metastasis, the median survival time was actually up at 33 months. Some people have argued that the low-grade designation also has a minority of patients who will do badly, including 5% metastasis and 50% fatalities. And so perhaps one way of viewing it is that low-grade is the new grade 2. So we know what we're doing with the most aggressive high-grade or grade 3 lesions, but we are trying to find the minority in the less aggressive tumours that deserve further monitoring and further treatment, whether they're called low-grade or grade 2. At this stage, with the margin assessment, the grade and the stage, we have the most validated information on which to base the use of systemic therapy, or in most cases chemotherapy. For patients with aggressive disease, I offer lomustine or chlorambucil, lots of other agents, receptor tyrosine kinase inhibitors and combinations, but the vast majority of my clients tend to opt for prednisolone and vinblastine. When used at the standard dose of 2 milligrams per meter squared, this protocol has been shown to prolong survival, and there were a couple of recent studies where we tried to have dose escalation because the standard dose is tolerated so very well, and even at doses of 3 to 3.5 milligrams per meter squared, most patients still tolerated the protocol really very well. As far as I'm aware, those fairly recent studies looking at the safety of dose escalation have not followed up with follow-up data to see whether that translated into longer survival in those patients, especially longer survival than the standard dose of 2 milligrams per meter squared of vinblastine, to suggest that dose escalation is efficacious as well as safe. The last bullet point on the slide echoes several papers recently that have hinted at longer-term survival following the use of chemotherapy compared to receptor tyrosine kinase inhibitors. But a lot of these studies are not randomized, so I wouldn't say that the evidence for that is very, very strong. However, compared to the last slide, there's also a lot of non-rational use of chemotherapy. And this is a bit tongue-in-cheek because, yes, it's kind of very rational to base things on the stage and the grade and sort of really robust parameters. But the owners, the clients that listen carefully, will typically catch on that I'm not using absolute terms like cure versus not cure. And some owners kind of don't do well with those kind of less than definitive expressions of risk. So for example, cure for us is a 4-letter word. And for some proactive owners, if I can say that their dog is definitely not missing out through not having chemotherapy, they may prefer the possibility of regret of a perhaps unnecessary complication on vinblastine to the regret of a recurrence or likely a dissemination happening after chemotherapy was not given when the mast cell tumour burden was at its least and perhaps most responsive. So some clients will want to go belts and braces and have all the possible treatments, even though perhaps most of the information does not robustly support that. And because there's very little risk with the vinblastine prednisolone protocol and its very short duration, I'm very happy to support these owners. So far, I've not mentioned much about the other histopathological tests that are available for mast cell tumours beyond standard grading and staging. And I do very much value the prognostic impact of tests such as Ki-67 or KIT immunohistochemistry and KIT sequencing. That's very well established. However, what I find is somewhat lacking in the research to date is a strong link to therapeutic decision making. There was a paper a few years ago that linked longer survival on chemotherapy to having highly positive KIT immunohistochemistry results in mast cell tumours. However, as shown in the inset picture, the development of such a reaction is often time dependent and is open to maybe some quality control issues. As recognised in the recent Oncology Pathology Working Group consensus statement. Also, KIT mutations of certain types, typically in exon 11 and 13, have shown better survival on chemotherapy, but also on massivet and palladia. But even when absent, those treatments are often, still very effective. And finally, there seems to be kind of an oscillation, or at least a lack of consensus, on how much additional information some proliferation indices add beyond a free mitotic index. This slide is a representation of my decision making for mast cell tumours in general in dogs. Each individual box has perhaps the more favourable outcome on the left of the box and the less favourable outcome on the right side of the box. So if we start off with FNAing pretty much everybody to know that we have got a mast cell tumour, then I often recommend a lot of preoperative staging, although I'm quite happy to do intraoperative staging and postoperative staging. I'm less enthusiastic about not staging because that leaves some questions unanswered, sadly. Next, moving down to surgery. So like I mentioned before, I'm very fortunate that most of my colleagues are far better surgeons than I am. So they'll be happy to perhaps offer a curative intent surgery to almost everybody. Admittedly, there are some locations and sizes of mast cell tumours that lend themselves to debulking, intentionally leaving some mast cells behind for radiation therapy to sterilize later. Ideally, the margin status, as the next line down, will be clear, greater than 3 millimeters all the way round. If it's not clear, then the green arrow would take us back to revision surgery, which is the best response, or perhaps radiation therapy in yellow. Perhaps the less good response to a close or dirty margin is to rely on systemic therapy to sort out this local complication or this local threat of recurrence. The last 4 boxes are basically the decisions that I take as to whether a patient is highly likely to benefit from chemotherapy or receptor tyrosine kinase inhibitor therapy, or whether that's probably not very necessary. So as I mentioned, grade and stage are very highly correlated in several papers over several decades with the need for systemic therapy and the benefit for systemic therapy. I do take into account some physical features like mucosal or recurrent or satellite lesions, and perhaps rely less on the additional histopathological features that I mentioned in the last slide, but all this plays into a decision about whether we give systemic therapy or not. And even whether we do or whether we don't give systemic therapy, the last box is a monitoring program into which everybody is offered entry, which is a physical exam at 1 month, and then every 3 months for 18 months, every 6 months for a further 18 months, and then annually thereafter. I would probably offer repeat staging at every second visit along that pathway too. So one thing that I haven't mentioned much so far is the emergence of Stilfonta over the last year or two. And I have to confess I don't have that much experience with Stilfonta, which probably reflects the fact that most of the surgeons that I work with are very well practiced in reconstructive techniques, so very little is considered inoperable by them. And while my view is that I don't see mast cell tumours coming back with a primarily surgical approach at the 11% that was reported in some of the Stilfonta literature, it still probably has a very significant role for some clients who would prefer a less than invasive approach to dealing with the primary mass. Although with Stilfonta there can be a wound which is typically granulating and healthy looking for the 4 to 6 weeks it takes to heal, that sometimes isn't so different from some of the more complex healing times for the more complex mast cell tumours that are operated on too. So that was kind of a whistle-stop tour through canine mast cell tumours, and we're next going to look at feline mast cell tumours, specifically the cutaneous, splenic and intestinal presentations. Firstly, with the cutaneous presentation, these represent some of the most common skin masses in cats, very easily diagnosed on cytology, although some of the DECVIM-CA stains used at the lab are more sensitive than the DIFF-QUIC stains used in-house. There's not really a classic presentation. Some of them can look very different to each other, but typically they will be raised, firm, sessile and hairless, and for most patients there isn't going to be any systemic signs. However, at a histopathological level, there's much variation between cutaneous mast cell tumour subtypes. The column in pink represents the well-differentiated mastocytic mast cell tumours, which are very easy to diagnose and typically also very easy to treat because they're well circumscribed and tend to only present a local challenge in terms of threat to the patient, so they tend to have an excellent prognosis after surgery. In red, we have what's sometimes referred to as pleomorphic or undifferentiated or anaplastic mastocytic mast cell tumours, which are the minority typically of cases, which have a much harder time for the pathologist to identify them, often with multinucleation or an infiltrative pattern of growth, leading to a greater risk of complications such as dissemination, especially when the mitotic index is high. And finally, and very distinctly, we have the atypical, or what used to be called the histiocytic form of mast cell tumours, which can again be very difficult to diagnose cytologically or even histopathologically, and are very distinct from the mastocytic mast cell tumours in many ways, which we'll come on to discuss. So taking the red and pink column from the last slide's table, these are the mastocytic mast cell tumours, which typically present in older patients, but can be present at any age at all. Also, they tend to be found more commonly in the Siamese, Burmese, Russian blue and ragdoll, mostly on the extremities and mostly solitary, but about 1 in 4 patients will have a multiple mast cell tumour presentation, and some of them will have very small masses throughout the skin and a medullary pattern. This form is typically easily diagnosed on cytology, and unlike dogs, there is perhaps a greater risk of degranulation and significant complications from degranulation. Personally speaking, I've not seen one of these anaphylactoid reactions myself, but lots of authors would highly recommend antihistamine and gastroprotectants as soon as a cytological diagnosis is made before surgery removes the bulk, if not all, of the disease. I don't want to draw too much of a corollary with canine mast cell tumours, but staging is important for feline mast cell tumours, especially if the patients have systemic signs such as vomiting or pruritus. Often on physical examination, we'll be able to find abdominal organ enlargement, commonly the spleen. And although typically only about 1 in 10 is metastatic, sometimes up to a quarter of patients have metastasis. So if a radical or expensive therapy is proposed, or typically if there are 6 or more mast cell tumours individually in the skin, then or miliary presentation, then staging becomes much more fruitful and much more impactful. This slide represents thorough staging for cutaneous mast cell tumours in cats, starting off on the top with the least invasive type of staging tests and going more invasive down the list. So I often start off with hematology or a buffy coat preparation and maybe some cytology or planned removal of the local lymph node. Imaging of the abdomen and chest can be useful, especially for liver and spleen outline and lymph node detection in the chest if the lymph nodes are enlarged, followed of course by aspiration of those enlarged organs such as spleen, liver and abdominal lymph nodes. Very rarely is it necessary to go to the extent of sampling the bone marrow, but if all of the other staging tests have been negative up until that point, for thorough staging a bone marrow sample is sometimes necessary. So this slide focuses on surgery for cutaneous mastocytic mast cell tumours in cats. I'll go on in a few slides to talk about atypical mast cell tumours and how they regress, and so sometimes surgery might follow a period of awaiting regression in those patients. But for mastocytic mast cell tumours in the skin of cats, surgery is the ideal therapy, as the vast majority are just going to be a local challenge and not have any risk of dissemination. There's also lots of evidence to suggest that margin status is less important than in dogs, and some studies will report that there is actually no impact in terms of prognosis on the completeness or lack of completeness of margins in cats. And so it's hard to kind of recommend that any type of surgery is fine, and it doesn't really matter about the margin, because that kind of doesn't really sit well with me as a message to kind of disseminate. But definitely in some studies, no recurrence, despite overtly dirty margins, no recurrence was found. For patients with very extensive disease, the preoperative or neoadjunctive use of prednisolone before surgery it can be successful, but is much less successful than its use in dogs to shrink masses before surgery. There is a partially validated grading scheme available in cats, but it hasn't been applied to more than just the initial population of cases. So hopefully that'll be fully validated very soon and will be shown to be prognostically significant in not just one data set, but multiple data sets. Hopefully until that situation arises, what we rely on is if the mast cells within the biopsy are very pleomorphic, if they're highly proliferative, or if they have certain other features such as multinucleation or irregular or prominent nucleoli. And this varies between each individual survey, each individual paper, but tries to kind of identify the more aggressive types of mast cell tumour from the less aggressive ones that are just a local challenge. In patients with proven metastasis on staging, or a grade or a suggestion of a grade that would be very consistent with a high risk of metastasis, then we can look at systemic therapy, for which lomustine has perhaps the greatest amount of evidence in favour of it. However, we do have lots of other choices very much echoing the dog, such as receptor tyrosine kinase inhibitors, vinblastine, lomustine, all sorts of treatment options. And finally, the outlook for mastocytic cutaneous mast cell tumours is typically very, very good. There was one paper in which recurrence happened in about 56% of patients, but that was very much an outlier. Most of the time we're seeing recurrence in less than 10%, sometimes 0% of cases, despite dirty margins. And if the disease is limited to the skin without dissemination, typically with just 1 or 2 mast cell tumours, then these almost exclusively will behave in a quite benign fashion. However, where there is dissemination, sadly, we're losing about 3/4 of the patients due to disease. We don't tend to have such a good outcome in those patients. Just before we move on to the visceral mast cell tumour presentations in cats, one slide on the so-called atypical, or what previously historically would have been called histiocytic mast cell tumours in the skin of cats. So these tend to be younger cats, typically less than 4 years of age. Again, the Siamese is predisposed, and again, they tend to be in the extremities, or what would be very surgically awkward areas. But the nice thing, if there is a nice thing about having these tumours, is that regression can occur, sometimes can take up to 2 years after the diagnosis is made, during which time some patients, or some clients rather, might lose their patience and opt to go for surgery anyway, just in case they're going to be in the unlucky scenario of not having regression. And the nice thing about surgery too is that wide excision is not necessary. Marginal excision often results in no evidence of recurrence and can induce regression in satellite lesions. So if one mass becomes problematic, perhaps a marginal resection of it will hasten the regression of the others, or so it seems, based on the few cases that have been published. Moving on to splenic mast cell tumours. Splenic mast cell tumour is the leading cause of global splenomegaly in cats. This picture is from a nodular spleen, which can also be another presentation. The typical cat with a splenic mast cell tumour will be older, like about 9 years of age, and will typically be symptomatic, unlike the typical cutaneous presentation. So will present for weight loss, maybe some gastrointestinal side effects, as well as anemia. Often these patients will have pallor on physical examination, perhaps ascites, but typically there will be an enormous splenomegaly palpable. As I mentioned, for the cutaneous presentation, there's probably an even greater need to have preoperative antihistamines and gastroprotectants here because of the huge volume of spleen that's taken up with mast cells, and so degranulation can be a significant problem with an anaphylactoid reaction. Sadly, at least a substantial minority, if not the majority of cases, will have metastasis at diagnosis, such as to the liver, lymph nodes, bone marrow, and also circulating mast cells in the buffy coat. And similar to the situation in dogs, sometimes infiltration of other organs can be inapparent on ultrasound, so we need to do an FLA of the other organs for thorough staging. For splenic mast cell tumours, there's an even greater need to have antihistamines and gastroprotectants because there's such a large volume typically of mast cells in the spleen ready to degranulate. So before surgery, we need to make sure that we have a decreased risk of an anaphylactoid reaction. The most common treatment is splenectomy, which commonly gives around about a year to 18 months of average survival, depending on the paper that you cite. But some of the research has been as low as short as 3 months median survival. Others have been much longer, up to 28 months median survival. Most papers have reported just surgery, and perhaps patients can be monitored thereafter for the recurrence of mast cells in the circulating blood or on a buffy coat smear, perhaps with additional slightly more invasive staging with imaging and cytology of the remaining abdominal viscera. And when any of these samples becomes positive again after splenectomy, then perhaps we intervene with prednisolone or chemotherapy. The negative prognostic indicators for this presentation include dissemination to other organs and the patient being symptomatic or with aggressive histopathological features within. The final presentation to talk about is the feline intestinal mast cell tumour, which is the third most common intestinal tumour in cats after lymphoma and adenocarcinoma. It typically affects an even older population of cats, around about 13 years or older, and often this is presented as the vomiting, losing weight, diarrhea, having gas, for which there's lots and lots of differentials. Interestingly, in one recent paper, about 28% of confirmed intestinal mast cell tumour cases in cats also had a confirmation of a T-cell lymphoma in their intestines. Often these patients have metastasis at diagnosis, typically to the liver and lymph nodes. And as I mentioned before, because there's still a large volume of mast cells in these patients, preoperative antihistamines and gastroprotectants are strongly advised. In terms of therapy, sadly, there's a limited indication for surgery because most of these are going to occur in a very vital part of the duodenum, and we can't guarantee good digestive function after an extensive surgery in that location. Sometimes we can offer debulking, but in a favourable, more distal location, we can look at a kind of a more curative intent surgery, at least locally. There are lots of systemic therapy options as per the cutaneous cases, either before or after surgery or instead of surgery for the patients who can't have surgery. But sadly, the median survival time tends to just be a handful of months, perhaps slightly more if there's a combination of surgery followed by chemotherapy too. And the very last slide is based on this controversial idea of a sclerosing mast cell tumour or a fibroplasia that involves mast cells in the intestines of cats. There were two papers a good few years ago that came out describing a similar type of lesion in the intestines of cats and reaching different conclusions as to whether it was primarily a mast cell tumour or not. However, they seem to be describing the same type of disease with a large amount of stroma and fibroplasia in which the mast cells are perhaps less frequently found than in the usual intestinal mast cell tumour mass, with very frequent metastasis to the other organs and sadly an even worse prognosis of just a couple of months for the average case in this presentation. So sadly the worst average survival for any type of mast cell tumour presentation in cats, sadly. And that's the end of my presentation on mast cell tumours in cats and dogs. I'm very happy to discuss your cases if you want to contact me, Richard Elders, by any of these methods, not just about mast cell tumours, but any canine or feline oncology cases. So yeah, I look forward to hearing from you in the future. Thanks, bye.